Buenos días, mi nombre es Erich de Paula, soy de Brasil y es un gran placer y honor participar en este importante congreso. Tengo que decir que lamento mucho no estar con ustedes en México, que tengo un gran cariño por su gente, pero sin embargo cuestiones familiares impidieron mi viaje. También lamento no poder hablar en español, porque sin Google estas frases no estarían saliendo, entonces pido permiso para hablar en inglés. I'm going to talk about thrombosis at unusual sites associated with COVID-19 and its vaccines. It is a great pleasure to be here. Thank you very much for the invitation, for the Congress Scientific Committee, and also for CLAHT. So let's start talking about some general concepts concerning thrombosis at unusual sites. The first one is that in the presence of any thrombophilic condition, the legs are the most likely place for a clot to start. I believe you're all familiar with the fact that the anatomy of the valves from the legs make them prone for the initiation of thrombi because of local hypoxia and inflammation. So concept number 2 derives from this one, which is whenever a clot develops elsewhere, and then we're talking about unusual sites, it suggests that the participation of very specific prothrombotic factors affecting the hemostatic balance locally at these vascular beds. So this is unusual exception. And third, we should remember that the scientific evidence that we use when we talk about VTE at unusual sites is of lower quality because it's mostly borrowed from what we know from PE and DVT. Now let's talk some basic issues about VTE and COVID-19. The first important question is, what is the real size of the thrombotic risk in COVID-19? You may remember that very early studies in the pandemic reported extremely high rates of venous thromboembolism, up to 75%. But these were very small studies, this one with 26 patients. They used systematic screening. Sometimes they looked for thrombosis in every patient several times a day. And not all patients were receiving thromboprophylaxis. As the pandemic went on, studies with higher number of patients, as is this case, and based on clinical suspicion, reported rates that were much lower. For example, 3.5% for patients at medical wards and 10% for patients in the ICU. And as a result, the most cited meta-analysis encompassing more than 18,000 patients reported that based on clinical suspicion, about 7% of patients in medical wards and 10% of patients in intensive care units with COVID-19 will develop a venous thromboembolic event. So this is naturally, obviously higher than in patients that are at home. And of course, COVID-19, we can conclude that it is clearly associated with a higher risk of VT. However, the most interesting questions are not these ones. Is this risk higher than in other respiratory infections? And also, does this risk also encompasses VTE at unusual sites? So, to address the first question, let's take a look at this very recent data published in 2022. And they compared the rate of VTE in COVID-19 before vaccines to the rate of VTE in a historical cohort of influenza patients. So, as you can see here, the squares, which are influenza patients, are always lower than the circles, which are COVID patients. So the conclusion here is that the risk of VTE in patients with COVID seems to be slightly higher than the risk in patients with influenza. Of course, there are several possibilities that could be introducing bias to this data, but this is the best data that we have, and we should go on with this conclusion. In regard to the second issue, whether VTE at unusual sites is proportionally more frequent after COVID than in other conditions, it seems not to be the case. This is data that was also recently published at Circulation, involving the data from thrombosis in 48 million adults from the United Kingdom. As you can see here, the frequency, the absolute frequency of portal vein thrombosis, cerebral vein thrombosis is very low. In hospitalized patients, it's almost an exception when you compare to PE and to DVT. So VTE wasn't common before the emergence of vaccine. And of course, please note that the frequency of PE is higher than DVT. This is something that we know for COVID. And this suggesting that in situ thrombus formation is important in COVID-19. And from that, we can derive that local prothrombotic triggers are more important than systemic. So the answer for the second question is that thrombosis at unusual sites did not seem to be a major issue after vaccine. So this was the scenario after 1 year of the pandemic. We had a higher frequency of VTE because millions of patients were having COVID and were being exposed. But the proportion of VTE at unusual sites was similar. Vaccines were eagerly awaited, and there were no signs of increased risk of VTE associated with vaccines in randomized clinical trials. And then there comes March 2021. You probably remember when people started talking about this unusual type of thrombosis after vaccines, particularly after the AstraZeneca and Johnson & Johnson vaccines. And these reports from the regulatory agents were quickly followed by 4 publications at the New England Journal of Medicine, which described this unusual condition that they called vaccine-induced immune thrombotic thrombocytopenia, because thrombosis occurred in conjunction with thrombocytopenia. So I would like to describe, go through in a case, one of the cases that were described by these authors, one of the index cases, so that you can see that this is very different from classical VT. So this was a 49-year-old woman with no prior health issue that had just taken the first dose of the AstraZeneca vaccine. In the first day, she developed myalgia and headache, which subsided, but on day +5, she started to have chills, fever, nausea, and abdominal pain. These symptoms worsened, and on day 10, she was admitted and presented a portal vein thrombosis and an incidental PE. What was unexpected is that she was also severely thrombocytopenic and presented very high D-dimer levels. She received platelet transfusions and was transported to a tertiary hospital, where she was admitted hemodynamically stable but presenting abdominal pain. After receiving antibiotics, analgesia, and prophylactic dose enoxaparin, her abdominal pain worsened, her D-dimer tripled, and a new CT revealed that the thrombotic had extended to splenic and mesenteric veins and also to aorta and to iliac arteries. She was started on intravenous heparin, but evolved with diffuse bleeding and death by shock. And autopsy also revealed cerebral vein thrombosis. So this is different than what we normally see in a patient that is admitted due to DVT or PE. This is a compilation of those cases reported in the first wave of reports. This was done by me. And as you can see here, thrombocytopenia is severe, median 27,000. Fibrinogen is consumed. This is a DIC-like picture. D-dimer is extremely high, and these patients are admitted at a median 10 days after vaccination, from 5 to 24. And females are overrepresented. What is most interesting is that now we're talking about a clear propensity for thrombosis at unusual sites. 70% presented cerebral vein thrombosis, 20% splenic vein, 23 PE and DVT, and of course you can see here that some patients presented more than one thrombosis, 18% arterial thrombosis with a very high lethality rate of 43.6%, which is of course very different than thrombosis, so that we can conclude that VITT or TTS, which was another term used to describe the same condition, are clearly different events compared to classical VTE. It has a propensity for VTE at unusual sites. It has an extremely high mortality rate. It associates with severe thrombocytopenia. It occurs only after the use of adenoviral-based vaccine, and it is rare. Let's talk a little bit about incidence. This is very recent data from the UK regulatory agency, which is a source that I always use when I describe that. And they have described 394 cases of VITT after 25 million first doses and 51 after 25 million second doses. As you can see here, this is almost a first dose only event. Okay, much less frequent after first dose. The case fatality rate has decreased because now we know how to treat, and most deaths occur after the first dose. Okay, so what about VTE without thrombocytopenia in relation to vaccines? Okay, so this is a very recent data, and it helps us to answer this question. This is retrospective data in which the frequency of VTE was compared before vaccines were available and then after vaccines were available. And as you can see here, there is a slight increase, but this was not statistically significant. So there seems not to be a significant increase in the rate of overall VTE, which is much more common than VITT due to the vaccines. And this is also recent data from Riete registry, which also goes in the same direction. I wanted to show here, they studied 102 cases of thrombosis that occurred 30 days after vaccination, any type of vaccination. Please note that thrombocytopenia can occur after thrombosis, even before COVID. This is a historical control. So 14% of patients with thrombosis had thrombocytopenia. For example, a PS cancer, these patients can have thrombosis. And when they studied the thrombotic events that occurred after mRNA-based vaccination, a very similar rate of thrombocytopenia was found, which is much lower than the rate of thrombocytopenia after AstraZeneca vaccine, suggesting that we're talking about classical VTE here and VITT with AstraZeneca. So events after mRNA-based vaccines are much closer to classical VTE in terms of mortality, association with thrombocytopenia, and other aspects, suggesting that we have two different possibilities when a patient gets vaccinated and develops VTE. Okay, so if we have two different situations, there must be a difference in the pathogenesis of VITT aside from the classical Virchow's triad. So what is this difference? Let's talk about it. Let's talk about pathogenesis. In order to talk about it, we need to quickly review three issues. First, heparin-induced thrombocytopenia. This is something that occurs 5 to 10 days after a patient takes heparin and he or she develops thrombocytopenia. This thrombocytopenia increases the risk of thrombosis, either venous or arterial. And this is caused because platelet factor 4, which is a protein present in alpha granules, are released from activated platelets. So these platelets are activated because the patient has an inflammatory condition. And PF4 binds to heparin, which is a polyanion, and these complexes of heparin, PF4, by binding to immune globulin receptors, can activate platelets, monocytes, neutrophils, and endothelial cells, leading to intense coagulation activation and thrombosis. So this is a coagulation activator that is mediated by a completely different mechanism. We're not talking about tissue factor here. We're talking about binding to immunoglobulin receptors on platelets and other cells. So what about platelet factor 4? This is a protein that has two different functions. The first one in thrombosis and hemostasis, we don't really know, but it seems to involve the modulation of the local hemostatic balance. But it has a very important function in innate immune response. It opsonizes pathogens and contributes to their eradication. So these antiplatelet factor 4 polyanions antibodies are actually a normal part of innate immunity. In fact, they are found in cord blood before individuals have been exposed to heparin or to vaccine or anything. So this is part of our innate immune system, and it helps us get rid of pathogens. However, if these antibodies are formed in a context in which the affinity to PF4 is very high, then unfortunately they can activate platelets and cause coagulation activation. So this is a study published in 2017, a long time ago. And as you can see here, antibodies from asymptomatic individuals, these are the good antibodies. They do not activate platelets in the presence of heparin or in the absence of heparin. However, if you take antibodies from patients that have developed HIT, if you put heparin in the experiment, then you have strong platelet activation. And there was one very rare condition in which a picture similar to HIT occurred in the absence of heparin. So antibodies to antiplatelet factor 4 polyanions were capable to activate platelets spontaneously, even in the absence of heparin. And these studies showed that these were antibodies that presented very high affinity for PF4. And finally, let's talk a little bit about adenoviral vectors. These are viruses that have been around for eons, and of course, our immune system learned how to handle them during eons of evolution. And one of the mechanisms by which we get rid of adenovirus, not vectors, is activating platelets by von Willebrand factor and PIF selectin. So, putting all this together, we can come up with a likely pathogenic chain of events. So, platelet activation is part of the natural immune system response to adenovirus. So, when in contact to adenoviral vectors, which resemble adenovirus, our platelets are activated and release PF4. This PF4 binds to polyanions from the vaccine, from vaccine components, and these form new antigens. This has been shown. This is a paper that was published last year, and as you can see here, AV is part of the vector, PF4 is the protein, and VITT is the antibody. As you can see, the antibody recognizes PF4 and components of the vaccine, and these are coating a platelet. And then these high affinity antibodies, they can activate cells that modulate the hemostatic balance, platelets and neutrophils, inducing the formation of neutrophil extracellular traps, which we know are very important for thrombosis in the venous and arterial systems. So this is probably what happens. Fortunately, this is an exception. Most patients that are vaccinated, even those that develop anti-PF4-PA antibodies, have antibodies that are not capable to activate platelets, as you can see in this study. Another important concept is that antiplatelet factor 4 antibodies causing VITT do not cross-react with the spike protein. This is something that was an issue, because if this was the case, then all vaccines could be a problem, and even a patient that developed COVID later would be at risk. But here you can clearly see that these antibodies do not cross-react with the spike protein. So, finally, let's talk a little bit about the clinical implications of all this that we have discussed. In regard to the laboratory diagnosis, it requires a history. Now we're talking about VITT, okay, not classical VTE. It requires a history of AstraZeneca adenoviral vaccine 4 to 30 days prior to the event. The clinical laboratory picture is marked by severe thrombocytopenia and extremely higher D-dimer levels. This is very similar to a DIC. In fact, it is kind of a DIC because there is systemic activation of hemostasis by this different awkward mechanism. There is a presence of anti-PF4 antibodies which are detected by ELISA. Interesting, they are not really detected by the assays that we use to diagnose classical HIT in our hospitals. No really clear reason for that. And here the functional assays to show that these antibodies are capable to activate platelet are less important than in HIT because the epidemiological clues here are quite straightforward. The patient was vaccinated and he's presenting a picture that is clearly different. So you have to treat these patients as soon as possible because if they are left untreated, mortality is very high, higher than 50%. As we will see, treatment is different than in classical VTE, so that a high index of suspicion is required so that early intervention is possible. And importantly, treatment should not wait the results of anti-PF4 antibodies because these are not really available in several places and they take time to be ready. So if you have a patient with thrombocytopenia, thrombosis, high D-dimer, you can go on and treat. As we will see now, this is an example of an algorithm. There are several others, but this is the one proposed by ISTH. It's divided in 4 steps. In the first step, you have to identify the suspect cases, and the suspect cases are those individuals who have a history of vaccination with the adenoviral vector-based vaccine and a suspicion of VTE. Then you go on to step 2. You try to make the diagnosis of VTE with imaging tests, and you confirm the presence of thrombocytopenia with a CBC along with a smear evaluation. So if you have a patient with a new thrombosis and a new onset confirmed thrombocytopenia, you have a case. Then you go to step 3. You request the anti-PF4 ELISA, but you do not need to wait for the results. If ELISA, you also assess coagulation activation with a PT, APTT, D-dimer, and fibrinogen. If the patient has a thrombosis, the D-dimer will be raised, and if it is higher than 4 times the low value for this algorithm, you go to step 4 and treat patients. And here's the main difference. As you might recall, coagulation is activated by the effect of these antibodies onto immunoglobulin receptors on cells. So you use polyclonal immunoglobulin so that it competes with the pathogenic antibodies and diminishes coagulation activation. You avoid platelet transfusions, you do not use warfarin, you avoid heparin, and you start patients on anticoagulants except in cases of major bleeding. And the preference here is for DOACs and fondaparinux. You should use fibrinogen. Remember that these patients sometimes bleed, depending on fibrinogen levels, and plasmapheresis has been shown to be effective in refractory cases. Other important management aspects that I would like to highlight, and these are important for patient orientation. There is no evidence that classical VTE risk factors increase the risk of VITT. As you have seen, these are very different mechanisms. So estrogens, thrombophilia, they do not increase the risk of VITT. Counterintuitive, but true. There is no room for thrombophilia assessment or for premedication with aspirin or low molecular weight heparin. So you should not give patients that before vaccine unless these patients already have a reason to take that. There is no indication to monitor D-dimer or to active screen for VTE after vaccination. And of course, in patients that have developed confirmed VITT, the next vaccine should not be adenoviral-based, but rather mRNA-based vaccines. So, I conclude with my take-home messages. The first one seems obvious but needs to be emphasized. Vaccines are not anticoagulants, so that individuals from all over the world continue to have VTE and arterial thrombotic events after they were vaccinated, and some even died after these events, and that doesn't mean that these events were caused by vaccines. As a matter of fact, vaccines stimulate the immune system, can cause general adverse events so that sometimes patients are more inflamed. Sometimes patients have to go to bed, rest, so that the baseline risk of classical VTE can possibly increase after vaccination. We don't have this data, but this is plausible. But then, so that a patient that presents a thrombosis after vaccine can have either one of the two conditions. Can have a classical VTE, which, as we have just seen, can occasionally occur at unusual sites, no difference in the proportion compared to prior to vaccine or even prior to COVID, or can have VITT, which is a different syndrome, requires immediate identification and a completely different management strategy. Risk factors for classical VTE are not risk factors for VITT, and the misdiagnosis of classical VTE as VITT, and this has been done, can be deleterious not only to patients but also to the general public, since it falsely increases the fear toward vaccines. It was a great pleasure to be here, and thank you very much for the invitation.